Now, the utility approach to the shoulder. Just before we do that, I'd like to just suggest a way of finding where the axillary nerve is, because you saw in the textbook it says 6 centimeters. Yes? May I ask you to come here? And may I ask you? Now, if you look at these two gentlemen, whose axillary nerve is 6 centimeters from the acromion? Mine might be because I'm Mr. Average, okay? But no one's average. Everyone here is special. So this young man's axillary nerve is not 6 centimeters from his acromion. It could be 3.5 centimeters. This lovely gentleman's axillary nerve could be 7 centimeters. So we have to have a way of trying to map that out without guessing. And I'm going to try and show you that. Thank you very much. Can I use your shoulder? Is that okay? As a fellow faculty member, I'm afraid you're like a model.
His genetic is up.
Can I ask you to turn around? We know that the deltoid muscle, if this is the lateral border of the acromion, this is the lateral epicondyle. The deltoid muscle inserts exactly halfway down the arm. Here's the spinal scapula, and at the very medial border of the spinal scapula is where the deltoid starts. A straight line between these 2 points. I mark it very gently here. 1, 2. A straight line marks the posterior border of the deltoid. This is normally 21 centimeters long. I know that because this is 21 centimeters in an average person. My middle finger points to the axillary nerve. So the axillary nerve is here. And it goes around the humerus almost horizontally. Now, if we drop the arm, and we find the lateral border of the acromion, we measure that distance there. It's less than 6 centimeters. Okay? But that's how you find the axillary nerve. And the way to test that on yourselves, if you do that on each other, is to press here, under the posterior border of the deltoid, and press towards the bone. And I tell you, it is painful, because that's where the nerve is. But it's a very secure way. Again, quickly. Okay. Sure. Here's the lateral border of the acromion. Here's the lateral epicondyle. Is down here. Halfway between the lateral epicondyle and the lateral border of the acromion is the deltoid tuberosity where it inserts. If we follow the spinal scapula to its medial border, that is where the deltoid origin is. A straight line between the two is the posterior border of the deltoid. Between your finger and thumb, the middle finger points to the axillary nerve. So it's quite consistent. If you measure halfway that distance, that is where the axillary nerve is, and then it goes perpendicular around the humerus. So it's like it's wrapping around here. Now if you drop the arm, this is where the nerve is. So we know that this nerve is within 6 centimeters of the acromion. Okay? And it's very constant. It's a good way of understanding where the nerve is, particularly if you're doing a posterior approach to the shoulder, transdeltoid approach, and eventually if you're doing proximal humeral fractures, it's also useful. Thank you very much. Now we do some slides. If we could see the slideshow, please. So next slide, please. So let's please look at the TV screen.
Guys, we haven't finished.
The one concept of dissection of the upper extremity is that we're looking for the nerves and protecting the nerves. So the anterior approach to the shoulder is all about understanding where is the axillary nerve in relation to the shoulder and protecting the musculotendinous nerve. And we'll see both of those in the next dissection. So next slide, please. That's the sequence that we're going to follow. We're going to, this position is not a bad position. I'll show you the incision and we'll go through the approach to the shoulder, the proximal shaft of the humerus. Next slide, please. Thank you very much for that. There are lots of different tactics. People like a straight incision, they like a curved incision, they like one lateral to the coracoid, over the coracoid, or medial to the coracoid. But like all surgery, it depends what you want to see. If you want to see the brachial plexus, you would go more medially. If you want to see the greater tuberosity, you would tend to stay more laterally. Either way, we want to avoid the fold of the anterior axillary fold because a scar contracture limits movement and is uncomfortable. Next slide, please. And then we're going to do the superficial dissection, and everybody says, how do you find the cephalic vein? Because this marks the deltopectoral interval. And we see a lot of dissection with a scissor or mosquito and this sort of dissection. Now that is, I'm going to try and show you a way that you don't have to do that is more respectful of the muscles and allows you to lift the cephalic vein away from the muscle without damaging it. I will try and show you that on our dissection. And then, next slide, we will see the superior border of the pectoralis major. And then we'll stop there and we'll go from there. So let's have a look at the dissection as we've done it already. And we've just made our incision with respect to the coracoid. We've got very good, thank you. So here's the coracoid, and I've made an incision that is slightly curving, like this, down, so I could, if necessary, extend it into the anterolateral Henry approach for a long plating if necessary, or take it medially to get to the neurovascular bundle and then come in to the forearm that way. So there are a number of ways of extending this incision, but what we're going to do now is just show you what we've been able to do already. And here we go. So we've raised skin flaps here and here. What I'd like you to do, if you will, is to try and raise these flaps without disturbing the fascia over the muscle. Do you see how this muscle is really coarse? It's a muscle that's very strong, but it's very coarse in its fibers. If you want to repair the deltoid, it helps to have its fascia intact, because that keeps the deltoid together. If I go under the fascia, I'll just show you that here, the muscle is very coarse, and suturing that is very difficult, so we keep the fascia over it. Similarly, the pectoralis major muscle is coarse. What I'd like you to do is to see that the pectoralis actually inserts into the deep fascia of the skin here. So there's not much between it and the skin. This is because it's part of the panniculus carnosus, the shivering muscle. But it has a very clear lower border here, and that's useful to see because underneath that will be the brachialis, the biceps brachii. But our job is to try and find the deltopectoral interval. When we did our incision, we came down onto the deltoid, so we know that the pectoralis is medial, and we undermine the skin here, and we know that this is pectoralis major. But what's the difference between pectoralis and deltoid? Instead of going straight forwards like this, what's helpful to do is to come along the surface using a knife blade, and you just peel the fascia off the pectoralis major. Excuse me. Is that at the outside? Here. And we come in underneath the fascia, and as we do so, the vein will lift itself away from us. Very good. Very good. So now we come in over here, and the vein is so variable. Sometimes there isn't one vein, there are two veins, or there's no veins, and the interval can be very difficult to find, but eventually you see the top edge of the pectoralis major, and down here we just allow the fascia to come away, here, and there is the vein here. So you notice I haven't really gone to find the vein has found me. And this is something I was taught by that great anatomist and surgeon, Ralph Hertel. So we like to follow his teaching here. And that then allows you to evert the deltoid. The cephalic vein, the cephalic vein is on the surface of the muscle here. And notice that it was actually under the muscle edge, not in the surface of the groove. The only way to find it safely is to come along the surface of the pectoralis major until you get to the deltoid. And then you see here, we can peel away the deltoid from its underlying bursa. And we can come all the way up here. Now, what we want to do then is to see here, just here, another vessel. See this coming across the interval here. This isn't the vein, of course, the vein is more superficial. This is the deltoid branch of the thoracoacromial artery coming across the interval, and there is a branch here to the pectoralis major. Here. Now, that's important because that artery comes down in the deltoid and comes to this anastomosis down here with the posterior circumflex vessel. And that can form an arcade of perfusion retrograde into the humerus in fractures. So it's worthwhile recognizing that and protecting it. Another reason to recognize it is that just up here, there is not uncommonly, in 1 in 10 people, and there's a prize to whoever can see it, a branch of the Deltopectoral nerve to the anterior deltoid. So the deltoid muscle can have a branch from the Deltopectoral nerve. Then if you come back to here, what we then want to do is to identify the pectoralis major, and I want you to enjoy this bit, because here we see the pectoralis major muscle, and underneath it, another bit of the pectoralis major. This is the deeper part. So I have the sternal head, and the clavicular head, and the sternal head underneath it. This is important if you want to use it for a muscle transfer for the subscapularis. So that's why we dissect it carefully. Okay? So what I'd like you to do, please, is to do that dissection. But can I persuade you, can I ask you, try not to use the scissors. We all were taught, and we are comfortable using these things, but they crush tissue. They rupture muscle. This thing treats it with respect. Okay, so try and do that dissection with the knife, just as I've done. It's a big knife blade, but it works very well. So try and find the cephalic vein by coming along the pectoralis major. Find the pectoralis major, inferior and superior border, and then the deltoid vessels here. Okay, off you go. We'll give you about 15-20 minutes for that. Don't hurry, enjoy it.
Faculty, please move clockwise. Faculty, clockwise on the next station. Clockwise.
So we carry on. Pectoralis major muscle here. What I've done is to separate it from its two heads. So here is the superficial head, which is the clavicular part, and if we incise that very carefully, we can fold it away, and you see the deep part, and here the sternal head of the pectoralis major. This is an important and potentially useful muscle in subscapularis insufficiency because, as Herbert Resch showed us, we can use that as a substitute for the subscapularis. And here we're now getting down to the reflection of the two heads of the pectoralis major. But now I can separate that if I want to. What I'd like to point out though is the point of safety. If we now evert the deltoid, you can see here the deltoid tendon, and here is the insertion tendon. Now to reduce the tension on the deltoid here, it's often helpful to release the footprint of the deltoid distally. So we can do that over about 1 centimeter. Here. So I'm just taking that off the periosteum, and then I can put in a curved humen around the humerus and retract the deltoid away without causing any harm to the anterior edge. You remember where the axillary nerve is? We said it was coming around the corner. But you see where my finger is pointing? Pointing almost directly at the upper border of the pectoralis major. So another clue as to where the axillary nerve is in any one individual is that it's opposite the upper border of the pectoralis major. So now, if we were to look up underneath the deltoid here, then, and we can do that by lifting the arm and releasing the deltoid from the humerus, and then, thank you. Opposite the top edge of the pectoralis major, coming in under here, will be the pedicle of the axillary nerve. And the clue to that is given by a blood vessel which comes across here, which is a branch of the posterior circumflex. That then tells you where the anterior circumflex is. So let's go over that again. By releasing the deltoid here, I can fold the deltoid back. Opposite the upper border of pectoralis major is the deep surface of the deltoid where you find the axillary nerve. It's given to us quite clearly by a blood vessel, which is normally in there. Oh, you can see it. Here it is on the deep surface. I've got it here. I can see the pedicle coming around here. Can you see my... Yes, you can. Good. Now, the importance of that is that quite often we see people putting Homan retractors here and then wrenching. Now, if you put your Homan retractor here and then do that, I'm afraid that may cause an axillary nerve palsy. So, when we put our Homan retractors for retraction of the deltoid, we should put them below, distal to the top edge, the superior border of pectoralis major, there, and another curve retractor, please. Thank you very much. And then up over the coracoid, which is here, to there. Now, this is the importance of releasing the deltoid here, because we don't want to tear the deltoid up here. Okay, so please can I ask you now to dissect the release of the deltoid, fold back the pectoralis major, try and find the two parts, and then look at the upper border of the deep part, and find the axillary nerve, and look at where the Hohmann retractors should never be. Thank you very much. So may I draw your attention again to the dissection? You've all done very well. So the next thing now, we want to find the guide to the rotator interval. The guide to the rotator interval and the lateral border of the conjoint tendon. So in order to help and see this clearly, I'm going to put a Hohmann retractor on top of the coracoid, and then we're going to lift the deltoid off that. So there's your coracoid. Actually, I've gone a bit too lateral there. Thanks. There you go. And we're going to retract the deltoid laterally a little. Thank you very much. And here we have the clavicular head, the clavicular head of pectoralis major. And here's the sternal head, so we're going to cut the sternal head. You don't have to do this in all trauma, of course. And today we're going to just cut that to get it out of the way, and that can fold back immediately. And that exposes this broad tendon, or more strictly speaking, it's an aponeurosis. A bit like a triceps aponeurosis. And of course this is the short head of biceps. And just under here is the long head of biceps, covered by the extension of the pectoralis major. So you cut that sheath here, and we see the muscle, the tendon of the long head of biceps. Ooh, my knife is getting blunt. Another blunt. There we are, there's the tendon. Now, my experience is, and we're going to do a study on this, is that if the long head of biceps and the short head of biceps join low down, then the musculocutaneous nerve is low down. If the bicep tendon and the short head of biceps joins high, then the musculocutaneous nerve is high. And why is that important? Well, if we put a retractor in the conjoint tendon here, and the musculocutaneous nerve is high, then we will kill the musculocutaneous nerve. So one observation we make is we find the lateral border, thank you so much, the lateral border now of the so-called conjoint tendon, and you notice that it's not at the edge of the aponeurosis, but lateral where the muscle part is, here. And then we can raise the muscle part, again, using a knife all the way, and we see here that the short head of biceps starts to join the long head of biceps quite distally. That should mean that the musculocutaneous nerve is coming halfway down in here, so I can put a retractor there gently and not risk the musculocutaneous nerve. Does that make sense? So we find the lateral border of the muscular part, not the tendinous part or the aponeurotic part, and we're going to dissect that off the subscapularis bursa. We're going to note its relationship with the long-headed biceps, and in this case, it attaches or joins together low down here, way down here, which is good, because the muscle, there it is, there's the muscle beginning to come through. And it doesn't join until way down here, so this muscular-cutaneous nerve is going to be very there. Now then, we follow the bicep tendon up, and we'll just shift you a little bit off there. And we keep elevating the deltoid off the bursa. And here, the outer border, the lateral border of the aponeurosis comes across the top of the front corner of the shoulder and forms a crescent. There's the crescent, and that of course is the free lower edge of the coracoacromial ligament. Okay, the coracoacromial ligament. And the bicep tendon is heading underneath its sheath towards the shoulder here. So that defines for us the top border of the subscapularis. So I'd like you please to dissect the long-headed biceps and find where it joins the short-headed biceps, which of course is the superficial part of this muscle. Okay, here. And work out whether your muscular-cutaneous nerve is high or low, roughly. Then follow the bicep tendon up, and the conjoint tendon and its extension into the coracoacromial ligament laterally. And the next step we're going to do after that is actually very interesting indeed. And I'd like to stop and hold just for a minute whilst we do that bit there, which is coming in under there. And I'll show you that in a minute. So let's give you 5 minutes to do that, and then I'll be back on the microphone. Thank you.